This meeting to order. So welcome everyone to meeting number 10 of the House of Commons Standing Committee on Health. The committee is meeting today to study the emergent situation facing Canadians in light of the second wave of the COVID-19, with our focus on mental health aspects. I want to thank the witnesses for appearing today. You will have 7 minutes for your presentations. For the first hour, we have, as an individual, Dr. Victoria Dawson, medical doctor. The British Columbia Centre on Substance Use, Dr. Nadia Fairburn, clinician scientist. Canadian Medical Association, Dr. Anne Collins, president. And the Canadian Mental Health Association, Quebec Division, Karen Hetherington, president. And for the second hour, we will have Faces of Advocacy, Dr. David Edward Waipun, founder, medical doctor. Mouvement Santé Mentale Québec, René Ouimet, director. Stepped Care Solutions, Dr. Peter Cornish, psychologist. Women's Health Research Institute, we will have Dr. Laurie Brotto, executive director, and Dr. Gina Ogilvie, associate director. Today's meeting is taking place in a hybrid format. I would like to start the meeting by providing you with some information following the motion that was adopted in the House on Wednesday, September 23rd, 2020. As we are now sitting in a hybrid format, that means that members can participate either in person or by video conference. All members, regardless of their method of participation, will be counted for the purpose of quorum. The committee's power to sit is, however, limited by the priority use of House resources, which is determined by the whips. All questions must be decided by recorded vote unless the committee disposes of them with unanimous consent or on division. And finally, the committee may deliberate in camera, providing that it takes into account the potential risks to confidentiality inherent to such deliberations with remote participants. The proceedings will be made available via the House of Commons website. So you are aware, the webcast will always show the person speaking rather than the entirety of the committee. To ensure an orderly meeting, I would like to outline a few rules to follow. For those participating virtually, members and witnesses may speak in the official language of their choice. Interpretation services are available for this meeting. You have the choice at the bottom of your screen of either Floor, English, or French. Before speaking, click on the microphone icon to activate your own mic. And when you're done speaking, please put your mic on mute to minimize any interference. And a reminder that all comments by members and witnesses should be addressed through the chair. Should members need to request the floor outside of their designated time for questions, they should activate their mic and state that they have a point of order. In the event that a debate occurs, members should use the raise hand function. This will signal to the chair your interest to speak and create a speakers list. In order to do so, you should click on the participants at the bottom of the screen. When the list pops up, you'll see next to your name that you can click raise hand. When speaking, please speak slowly and clearly. Unless there are exceptional circumstances, the use of headsets with boom microphone is mandatory for everyone participating remotely. Should any technical challenges arise, please advise the chair. Please note that we may need to suspend a few minutes as we need to ensure that all members are able to participate fully. For those participating in person, proceed as you usually would when the whole committee is meeting in person in a committee room. Keep in mind the directives from the Board of Internal Economy regarding masking and health protocols. Should you wish to get my attention, signal me with a hand gesture or at an appropriate time, call out my name. Should you wish to raise a point of order, wait for an appropriate time and indicate to me clearly that you wish to raise a point of order. With regard to a speaking list, the committee clerk and I will do the best we can to maintain a consolidated order of speaking for all members, whether they are participating virtually or in person. So we will now go to the witnesses. So welcome to all witnesses. And we will start with Dr. Victoria Dawson. Please go ahead. Doctor, 7 minutes, please.
Thank you so much for inviting me today, honorable members of the committee and all the witnesses. I am Dr. Victoria Dawson. I work up in the rural aspects of Ontario in Wasaga Beach and Collingwood. I have a family practice. I'm here today to talk about the impact of the COVID second wave on our seniors primarily, since that's the majority of my population. And I felt it was important to get the community aspect of what's going on. So I do both nursing home care, plus I do have a clinic. So the biggest issues, and I had quite a number of meetings with my clientele, there's a lot of concern. There is limited help for seniors, and I realize that there's been a lot of virtual care going on with regards to mental health. However, unfortunately, my seniors are 80 and 90 years old and unable to access things like smartphones or internet or even use a computer. Many of them have been left alone by themselves at their homes or nursing homes because they're isolated from other members. We have multiple health issues going on with our seniors, such as dementia. They are unable to recognize people over video. They do better with in-person visitations. We have patients with COPD that are breathless, that just can't hold a conversation necessarily on video, or they can't make enough sound to be heard. So it's very difficult for them to speak on the phone or on virtual media. Deafness is a huge one. I find that when I do telemedicine, my patients cannot hear me. So when they're trying to connect with other seniors or with their family members, they cannot hear anything, which is very problematic, and it's very difficult to overcome. Even speech disturbances, very difficult sometimes, as we have figured out with my microphone, to be heard. Visual disturbances, can't see their family members. Maybe they have a distance field deficit and they're not able to see their family members. These seniors have communicated to me that they're very lonely. A lot of them are actually expressing suicidal ideation and wanting to die because they just can't face another months or 2 months without being able to communicate or see their family members. There is different community members that are trying to reach out to seniors that have expressed some concerns as well. Some of them are, one is the smart devices are unable to access care. The fear, that's the other issue. So because they don't have access like you and I do to different resources to tell them what's going on in the community, unfortunately, the media is driving a lot of the fear, and I'm finding a lot of my seniors are not coming in to be seen or their medical problems being treated because they are just so scared to go. Personally, I had a really nice lady that sat with abdominal pain for 8 months, and then we found out that she had advanced stage cancer. And unfortunately, it was diagnosed in the emergency department because she was too scared to go anywhere else for months. We are, and just a general lack of nursing home attendance with regards to COVID, protecting these patients. There's been a grand, how can I say, they've been completely neglected. But in trying to protect them, we're also harming them. So I think that I'm here to try to say if we can actually do something for these patients and try to find a balance so that they're able to communicate with the outside world, create social circles for them, because they thrive on being able to talk to other people. I'm here to say that we need better mental health services for our seniors. A lot of the mental health is great, and I have referred to people to virtual care like Bounce Back in Ontario. But with the seniors, they're not able to communicate through those devices. So they're often left with nobody to talk to. The nursing homes are understaffed. A lot of the family members were going in and helping their seniors, whether it's cooking them meals or helping them get dressed. And now they're left in their rooms and not able to communicate with them or get the extra help that they need. So I'm here to speak up for this population that has been forgotten. In protecting them, we have harmed them also. And I think that we just, as a committee, as humans, as healthcare providers, we really just need to reach out to that community and make sure that they're well protected. Many of them say to me, they've got 1 or 2 good years and they want to spend the 1 or 2 good years being able to be with family. So how can we make that happen? And I know I'm running out of time. I just want to also touch base on the communities, our middle class communities, working class family members that are not able to make ends meet. I've had a significant increase in this community with drug abuse, alcoholism, and that's actually amongst the seniors as well. So people forget that this is how they're trying to deal with their problems as well. Realizing that I understand why businesses are closed, but they have their entire life invested in them. We're seeing the reverberations in the children. The children are in turbulent environments and they're not able to cope with this. We're seeing a high rate of depression and anxiety in as young as like 5, 6 years old when they're realizing what is happening to them. They don't necessarily understand what's going on at school. They understand about a virus, but they can't understand why mom and dad can't pay their bills or why they have to go to the food bank this week. And not knowing where the next paycheck is going to come from. I've had some families also become homeless during that, and there's no support for them. And I'm really spinning my wheels in my community and trying to make sure that everybody's well taken care of. But frankly, I don't have the resources for these patients. And I'm at a loss of what to do. And I've talked to other members in my community, and they're all also expressing the same concerns. The high rate of suicidal ideation and the amount of mental health that's coming in through the emergency departments is something that we can't even handle. So we're really in the rural communities, we're really needing help. Seniors are number one. They're the ones who are suffering the most, but I just want to highlight what we are dealing with as a family medicine perspective. I'm getting these patients help. Maybe it's financial assistance. We need
That's 7
something.
minutes, Doctor, if you could wrap
Thank
up
you.
quickly.
Yes, thank you. I'm done. Thank you.
Right. Thank you very much. We go now to Dr. Nadia Fairburn, clinical scientist at British Columbia Center on Substance Use. Dr. Fairburn, go ahead, 7 minutes.
Good morning, Chair Ron McKinnon, Vice Chairs Luc Thériault, and Honorable Michelle Rumpel-Garner, and members of the Standing Committee on Health. My name is Dr. Nadia Fairburn. I am a clinician scientist and an assistant professor in the Department of Medicine at the University of British Columbia. And I am here on behalf of the British Columbia Center on Substance Use, a provincial organization with a mandate to develop, help implement, and evaluate evidence-based approaches to substance use and addiction throughout the continuum of care, from prevention to treatment to harm reduction and to recovery. I've been invited to speak here today regarding the impact of COVID-19 on mental health and substance use for Canadians. I will focus on substance use while acknowledging the intersectional impacts of this pandemic on population levels of depression, anxiety, domestic violence, and adverse childhood experiences, among others. Let's look at alcohol, our most commonly used substance in Canada, and one that was responsible for $15 billion in health and social costs in Canada in 2018. Alcohol intake in excess is linked to increased mortality, cancer risk, and other chronic conditions, though many Canadians and clinicians are unaware of Canada's low-risk alcohol drinking guidelines. A recent NANOS poll found that pandemic-related alcohol consumption is increasing across all age groups in Canada. A recent CIHR study found that nearly 1 in 4 respondents reported consuming more alcohol, both in quantity and frequency, during the pandemic. The issue is particularly pronounced among 18 to 34-year-olds, with nearly half reporting an increase. And nearly 1 in 10 Canadians who drink alcohol say that they have had issues with controlling their ability to stop drinking since the start of COVID-19. Due to time limitations, I'm not able to comment on other legal drugs such as tobacco or cannabis, but these are also responsible for mounting health and social costs and harms during COVID-19. We know with certainty that increased consumption of substances is associated with an increased burden of social harms, health harms, and dependency. So why is this happening? Consuming substances like alcohol is a way for some people to manage or control their stress, as well as symptoms of depression or anxiety during the pandemic. In addition, recognizing our societal dependence on alcohol and fearing the fallout from restricting access to alcohol during times of public health lockdown, most provinces except PEI declared liquor retail an essential service. This was a sound decision given that without proper care, alcohol withdrawal can be a life-threatening condition. In order to ease the financial burden on the hospitality industry, municipalities also relaxed restrictions on access to liquor by permitting restaurants to offer alcohol for takeout with takeaway food. Retail markups on liquor were also reduced. In the case of illegal drugs, the situation is dire. The overdose crisis continues to have a significant impact on Canadian communities and families. With an average of 11 deaths and 13 hospitalizations every day between January 2016 and March 2020. It is one of the most serious public health crises in Canada's history. During COVID-19, overdoses and fatal overdoses across Canada are occurring at the highest rates ever recorded. Deaths in British Columbia hit new highs over the spring, including a monthly record of 181 illicit drug toxicity deaths in June. The province is now on pace to see the highest number of overdoses in 1 year, 5 years into declaration of the public health emergency in the province. Alberta revealed in September that 301 people in the spring died due to overdose, also a record. In Ontario, overdose deaths jumped by nearly 40% in the first months after COVID-19 hit the province, on pace to extend 2,200 overdose deaths, the highest on record. Overdoses have taken far more lives than COVID-19 in these 3 provinces, which are the hardest hit by the opioid crisis. Yet our response has been muted in comparison, even more so than with mental health. The unmet needs, already large, are increasing. On a personal note, this has been the most challenging time to practice addiction medicine. I've had to make several calls to families and loved ones following the loss of a patient to overdose during the pandemic, and my heart goes out to each of them who are suffering and grieving. It is every community in Canada that is being affected. There are many reasons why overdose deaths have gone up during the pandemic. First, contamination of the illicit drug supply with synthetics, fentanyl and its analogs, as well as other poisonous substances such as the very potent benzodiazepine atizolam, has driven the overdose crisis in Canada since 2016. During COVID-19, changes in the illegal drug supply as supply chains have been disrupted by travel restrictions and border measures have led to further poisoning of the drug supply in Canada. At the same time, there has been less access to supports and services for people who use drugs, as well as hesitancy to seek treatment through the healthcare system due to concerns regarding COVID-19 risk in healthcare settings. This has led to reductions in use of harm reduction services, such as supervised consumption sites, as well as reduced access to treatment services like detox and recovery beds. Substance use, including relapse rates, have increased as many struggle to cope with stress during this difficult time. There are a number of actions that can mitigate the increasing harms we're seeing due to substance use during COVID-19 second wave in Canada. We need to raise awareness of the potential harms of alcohol use and encourage people to follow safer consumption and lower risk drinking guidelines. We need to understand and anticipate that the pandemic may lead to increased risk of relapse for those in recovery from substance use disorders. We need to improve screening and treatment of people at risk for relapse to substance use, to improve access to evidence-based treatments and recovery-oriented services as part of a comprehensive system of care for addiction. There is a pressing need for more evidence-based clinical guidance and more training of health professionals to equip them with the knowledge of care for substance use and addiction to build capacity in the health system. Access to pharmaceutical alternatives is needed to prevent overdose and other severe harms caused by a contaminated illicit drug supply. Finally, I agree with the Chief Public Health Officer of Canada, the Canadian Association of Chiefs of Police, and Moms Stop the Harm, a network of Canadian families impacted by substance use-related harms and deaths, that to mitigate pressing harms of substance use and in order to be able to treat addiction as the medical condition it is, decriminalization of people who use drugs, as was unanimously endorsed by Vancouver City Council just last week, is essential. I'd like to thank Ms. Cheyenne Johnson and Dr. Perry Kendall at the BC Centre on Substance Use, BC Health Minister Adrian Dix, and BC Provincial Health Officer Bonnie Henry for their leadership in BC during this time of need. Thank you very much for your attention.
Thank you, Doctor. We go now to the Canadian Medical Association, Dr. Ann Collins, President. Dr. Collins, please go ahead, 7 minutes.
Thank you, Mr. Chair. It's my honor to appear before you today. My name is Dr. Ann Collins. In a 3-decade career, I have taught family medicine, run a full-time practice, served with the Canadian Armed Forces, and worked in nursing home care. Today, as president of the Canadian Medical Association, I am proud to represent our 80,000 members, so many of whom have been working all out for over 9 months and counting. Our health systems and the people who work in them were stressed well before then. Now we are at a tipping point. I am deeply concerned about the mental health of Canadians. I am deeply concerned about my physician colleagues and healthcare providers who work alongside them. Psychological trauma is anticipated to be the longest lasting impact among healthcare workers in the post-pandemic environment. After almost a year on the front lines in untenable circumstances, burnout is a grave concern. We are sounding the alarm. When Canadians banged their pots and pans, they shouted their support for those risking their lives on the front lines. The pots are now nestled in the kitchen drawers, but the pandemic has not stopped. It's worse, and the risk to frontline workers persists. At the pandemic's onset, a lack of coordination of emergency supply stockpiles among federal and provincial governments led to inadequate deployment of supplies, such as ventilators, and a widespread void of sufficient PPE for frontline healthcare workers. Physicians were faced with the ethical dilemma of being unprotected while treating patients and potentially putting their families at risk, in addition to having to make decisions about allocating life-saving intervention. The explicit anxiety haunting frontline physicians is palpable. They are at high risk of developing symptoms of burnout, depression, psychological distress, and suicidal ideation. Grueling work hours, uncertainty, fears of personal and family risk, experiences with critically ill and dying patients, these conditions create unprecedented anxiety. Physician burnout was a nationwide challenge long before the COVID-19 pandemic emerged. In 2018, 30% of physicians reported high levels of burnout. The outcomes of human health resource issues, system inefficiencies, and overcapacity workload creates a culture of sustained burnout. No amount of therapy, yoga, or mindfulness will make it go away. And the consequences reach much further, Mr. Chair. They lead to bad patient outcomes. We are calling on all levels of government and health authorities to work together to protect Canadians and healthcare providers during the second wave of COVID-19 through a series of 4 strategic investments and actions. First, that all governments recognize and raise awareness of the need to support healthcare providers as part of their public education messaging on COVID-19. There is nothing benign about remaining mute on this subject. Patient safety depends on the mental health stability of medical professionals. Second, that the federal government invest in the creation of a mental health COVID-19 task force that mobilizes national mental health associations and professionals to support the mental health needs of care providers during and following the resurgence. And that the government increase funding to jurisdictions enhancing access to existing but strained specialized mental health resources for healthcare providers. Third, our vulnerable populations and people living in rural remote areas are disproportionately affected. The federal government must fund and implement sustainable, evidence-based mental health services and supports to respond to the increased demand for mental health care resulting from COVID-19. We must also intensify access to critical social support services and embed virtual care. We welcome the commitment to expand broadband across the country. It has the capacity to create equitable access to virtual care. But the success of digital healthcare relies not only on broadband expansion, but the development of digital health literacy programs, and measures to ensure equity of access for marginalized populations. Lastly, we simply cannot ignore the risk of a healthcare shutdown. Avoiding this is absolutely critical. Following public health measures is needed, as well as federal investment. A healthcare and innovation fund of $4 billion in federal funds would address the backlog of medical services, expand primary care teams, and boost the capacity of public health. These measures don't exist in a vacuum. It is their combination that blazes a path to Canadian health security. Canadians need the confidence that their healthcare system is there for them, that the physicians and frontline healthcare workers are in good shape. With burnout becoming the most significant challenge to the healthcare system, we face a degradation of care for our patients. Every tipping point needs a steadying hand. Canada is reaching out for it. Great victories require two elements, a common enemy and solidarity. We have a common enemy, it's viral, but without solidarity, there will only be more harm and loss. This virus doesn't care about politics. It doesn't recognize federal, provincial, or territorial lines. It doesn't care about a perceived stake. And these case numbers aren't numbers, they are lives. And we must fight for them, all of us, together. Mr. Chair, let me thank the committee for the invitation to share the convictions of Canada's physicians.
Thank you, Doctor. We'll go now to Canadian Mental Health Association. Ms. Hetherington, President, please go ahead. 7 minutes, please.
Bonjour tout le monde. Hello, everyone. Thank you for this invitation today. I will be making my presentation in French, so I hope interpretation will come through. I am the president of the Canadian Mental Health Association, but I'm here on behalf today of the Quebec Division. I'm not going to talk about statistics because Dr. Fairburn and Dr. Dawson and Dr. Collins well explained this impact. I will speak mostly about what we're able to do. I want to discuss with you the possible solutions to this crisis we're experiencing. Everyone is being affected by COVID, but we're all affected differently. The question is this: how can we change this trend or direct this trend to have a comprehensive impact on the Canadian population? In 2019, the Canadian Mental Health Association published a document entitled Cohesion, Cooperation, Community. We want to promote mental health in Canada. For us, mental health promotion is the last frontier. It is truly an issue to develop and explore. Prevention is truly centered on the reduction of symptoms, but promotion is centered on positive mental health. We must cultivate positive mental health both individually and collectively. We must design interventions throughout one's life for youth, for the elderly, for seniors with various experiences in life, and in different communities and organizations in schools, in rural contexts, in the workplace, etc. The good news is your mandate. The federal government has said that it's responsible, so it can have very targeted leadership in this crisis. The promotion of mental health is inclusive because it targets everyone. It targets those who've already been diagnosed with mental illness, with people who are at risk, and it allows the development of interventions, campaigns that will respect these differences, but that also will ask for perpetual, constant change throughout this crisis. For example, At the beginning of the pandemic, I don't know if you remember, but throughout the country, we used the rainbow image, and we were saying it's going to be okay. In French, ça va bien aller. It was very comforting in March and April. But in December, is it as reassuring? Is it going to be as reassuring? This is rocket science. What will speak to me may not speak to you, and it would perhaps not speak to the vulnerable people in our society. We believe in our Quebec division that we need a community mental health program. We want to have a campaign that will speak to the most vulnerable in our communities in various ways. We want to reach out to them. Community organizations have direct knowledge and understanding of the vulnerability of individuals, families, and communities. And there are other levels of exclusion that intervene. Those who have spoken before me today have given evidence of this. It's our most vulnerable in our communities who need an extra layer of help because they're really suffering from exclusion. So what can we do? We believe that the only way of intervening is with our community organizations. Mental Health Week was promoted. We've been promoting this for 70 years. We talked about getting loud these last 5 years, and now we're saying with the pandemic, let's get real. Getting real is the name of the campaign. We need comprehensive programs. We need targeted interventions that speak to the various needs of the population. And the only way to do this is through the promotion of mental health via our pan-Canadian organizations. I have other examples here in Quebec. People can't stay connected as they age. Technologies are not offered to everyone, and we really have to be innovative. And I stated it's rocket science, and we do need community organizations because the benefit of all these community movements is that they can change on a dime.
Virus gives us the opportunity to live continuous uncertainty, and we need to turn on a dime. Alors, mes recommandations sont très claires.
So my recommendations are very clear. The government must make a commitment to supporting mental health because it's been proven that it's not just the direct impact of COVID that will be a problem, but there'll be a problem within our entire healthcare system. So I'm recommending that the federal government support community mental health across Canada with a specific mandate to develop innovative mental health programs for promoting mental health that are adapted to the present context. These programs should foster positive mental health through positive messaging to our diverse communities and promote the connectivity of citizens in their homes, schools, communities, and in their workplaces. Thank you. Thank you, Ms. Hetherington.
So we will start our questioning now. We will have time only for one round of questions on this panel. So we will start with Ms. Rempel-Garner. Please go ahead, 6 minutes.
Thank you, Chair. I had a bunch of questions prepared, but I have to say what I just heard, particularly from Dr. Fairburn and Dr. Dawson, is very sobering. So I would frame out what I heard from the two of you this way. There are, first of all, acknowledging that COVID-19 is serious. It's something that we all have to work together to prevent. Not putting any question there, but the prolonged impact of the impact of the measures that we've seen have had significant corollary health impacts. I heard everything: mental health, isolation and suicide risk, opioid deaths, increased in substance abuse, the delays in surgery, increase in domestic violence, increased rates of depression, And I think the line that stuck with me the most is, in trying to protect them, we're also harming them. This is what's been keeping me up at night as a policymaker, is how do we protect the public from COVID-19, but at the same time understand that we may be causing harm. And it's an area I don't know how to talk about as a legislator, because I don't want to diminish the severity of COVID-19, but at the same time, there's a serious problem here. So I guess I would ask, and I'm going to divide my time between the two of you, Dr. Fairburn and Dr. Dawson, because you're on the front lines right now. For each of you, what are 3 short-term recommendations? And I know, like, just to Dr. Collins and Dr. Hetherington, we need longer-term solutions to deal with the healthcare system in Canada. I couldn't agree more. But to Dr. Fairburn and Dr. Dawson, if you were sitting in my role right now, what are the 3 things you would do to make a short-term change to get to that nexus where we're protecting people from COVID-19, but also addressing some of the concerns that you raised? So why don't I start with you, Dr. Fairburn? And I only have 4 minutes, so if you could keep your comments very short, that would be helpful.
Sure, thank you so much for that question. It does feel as though COVID-19 has pulled back a layer of in terms of what was already not adequate with the addiction treatment system. When it comes to areas of urgent need at the intersection of COVID-19 and addiction, first, we need urgent scale up of service access to evidence-based services for addiction. So that includes harm reduction services like supervised consumption sites in naloxone. That also includes detox and recovery beds. I've had numerous clients who want to access detox who've relapsed during COVID-19, and those services are all scaled down due to COVID-19 precautions. So scale up of all services that are needed for addiction treatment would be first. Second, we need expansion of access to pharmaceutical alternatives to the drug supply. Fentanyl is not going away. The contaminated drug supply has only gotten worse with COVID-19, and this is not going to miraculously resolve itself. And so we really need to be able to offer people who are wanting to prevent overdose and fatalities for themselves and the impacts for their families and communities, urgent access to these medications.
So Dr. Fairburn, I only have 2 minutes left, and it goes so fast. So I want to give Dr. Dawson a chance to get in just with her perspective and rural and remote treatment right now as well. As Dr. Fairburn said, like, what are the most urgent things at that nexus between the COVID policies that we have right now and the corollary health impacts? What could change? What could we be doing differently right now to stop some of the issues that you're seeing?
Well, I think we really need to start connecting our seniors with some sort of mental health and trying to make it in a safe way. So accessing rapid testing so that people can actually go in and see these seniors. They live for their families. We need to reconnect them. We need to get counselors or anybody to see these patients face to face. Unfortunately, unlike us who are in the digital world, we can connect with people. Unfortunately, seniors never grew up with this. They maybe were introduced to this maybe 15 years ago. That's not enough. They need to be able to connect and see people and see facial expressions and see their grandkids or their family members. I think accessing the rapid testing so that this can happen. Creating a safe bubble community for our seniors. So having 5 or 6 people that they can connect with safely, once again, using things like rapid testing. 15 minutes in their world is fine, but we can't wait days, weeks, months for testing to come back. I'm seriously concerned about the amount of alcoholism that is being used by seniors, because they are using that just as younger persons are to deal with this. And patients have come to me and they finally broke down and came to the office and said, Dr. Dawson, I can't do this anymore. They saw that article and say, I want to be referred to MAID because I can't, my whole life is my family. So they see those articles and they say, I don't want to live anymore. And so what do you do with these seniors that can't reach out? They can't use Bounce Back in Ontario because they don't have a computer. We really need to try to create a group for them, whether it's social distancing coffee hour for seniors to talk about things, or get them connected with their families, and try to stop that wheel of fear, because family members don't want to go visit grandma and grandpa because they're scared of causing them to die. But the realistic aspect is that they'll probably die from something else sooner than possibly COVID, especially if we put proper checks and balances in place.
Could you wrap up your answer, please?
Thank you.
Thank you to you both.
Thank you, Ms. Rempel-Garner. We go now to Mr. Fisher. Mr. Fisher, please go ahead, 6 minutes.
Thank you very much, Mr. Chair, and thank you so much to all of our experts who are here today, and we really appreciate your testimony and your opening statements. I'm going to focus my comments and questions to Dr. Collins, fellow East Coaster, and thank you, Dr. Collins, for your service in the Canadian military. It's so clear that mental health issues have spiked during COVID-19. I'm wondering, Dr. Collins, if you could talk about some of the key populations you're most concerned about and how maybe the government can better support these people during COVID-19.
Thank you very much for the question, and through you, Mr. Chair. Firstly, I am here representing the 80,000 members of the Canadian Medical Association who have been on the front line tirelessly for the last 9 months, and I want to thank them and acknowledge their service and their commitment, but I also want to emphasize and acknowledge what they are currently dealing with. They have already had high levels of burnout, as we showed earlier in 2018, but during this pandemic, they've had to deal with uncertainties around PPE, and we hear that that still exists in some parts of the country. They have concerns for their families and for themselves, and care daily for people with COVID-19, but also with people impacted by what you've heard previously from previous speakers about COVID-19. So for them, we call upon government to establish a COVID-19 virtual care task force to look at their impacts, to make a strong commitment with public education messaging around the need for support for healthcare providers. Other populations that have been profoundly impacted, and you've heard most eloquently from the previous speakers, include our seniors. But I also want to put some emphasis on our youth. In my practice, in the last 30 years, I saw an increasing level of anxiety amongst adolescents and even pre-adolescents, and that impacted their schooling, their relationship with family, relationship with friends. And I and their parents struggle to find adequate resources to serve their needs. I can only imagine what COVID-19 has done with that age group in terms of their disruption in the types of schooling that they're having, and with loss of social contacts, with concern about the pandemic, about who's in and who's not in their bubble, and who they can see and who they can't see. So again, calling upon enhanced social support and services in a coordinated way between all levels of government and health authorities to service this population, as well as seniors, our Indigenous communities, people living in rural and remote Canada.
Thank you, Doctor. One of the first things that this government did was during the renegotiation of the health accord is we invested an additional $5 billion over 10 years specifically dedicated to mental health. Are you seeing the results of this investment yet in healthcare systems across the provinces and territories?
So we support investments that have been made to support mental health in the past, and investments that have been made to support what's happening now in the pandemic and what's been happening since March. I think really what our need today is to emphasize, regardless of what's been done in the past, it's to see what's happening now and to be very acutely aware of what's happening with our healthcare providers, as well as our vulnerable communities and Canadians across the country in general. And so we need to look at ways collectively, collaboratively on how we can improve the delivery of service, improve access to service, improve numbers of professionals providing that service. So we really need to look forward, look to now. We need to, first of all, in part to control what's going to happen from the mental health perspective, is also, let's not forget, is to control the transmission of the virus right now, and what the needs will be in the short term and the long term as a result of this.
Any time left, Mr. Chair?
Yes, you have almost 3 minutes.
Almost 3 minutes.
Oh, I'm going to have to defer to the clerk. Seems like my clock is not working. Mr. Clerk, one minute left.
1 minute left.
Thank you. Thank you. Dr. Collins, the outbreaks and deaths in long-term care homes across Canada is one of the greatest tragedies of the pandemic, and likely one of the greatest tragedies of our lives. The mental health impacts of those in long-term care must be profound. How can we support those not only living in long-term care, but as well as those working in these facilities as well?
So that is a critical point in terms of those healthcare providers and all those who work alongside of them. So again, it's to have enhanced services within provinces, within those areas, to target the type of support that those providers need. We need those people to be in good shape. We need them to carry on. We need to know, they need to know that they're supported. We need to show that they're supported by putting boots to the ground, access to the care that they need.
Thank you, Mr. Fisher. We go now, nous allons maintenant à Monsieur Thériault.
We'll now go to Mr. Thériault. Mr. Thériault, you have 6 minutes.
Oui, Monsieur le Président.
Yes, Mr. Chairman. I didn't hear you. I was waiting for the interpretation. I'm guessing that it's my turn. There was a bit of a gap there. First of all, yes, it's your turn, says the chair. Thank you very much, Mr. Chairman. So I guess we're putting the counter back at 0. I would like to thank all of you. We have a general idea of what's going on in the area of mental health. We have people around us. We have people who are depressed, anxious, suffering from anxiety. We do wander about. We see people. We have our phones in our riding offices, etc. But this morning, I sensed that the reality was really hitting us very hard. The witnesses who came to see us during the first wave told us that the pandemic was showing us directly in our faces what we haven't done properly. And what we haven't done a good job of was work on the first determinant of health, which is prevention. So it's hitting us in the face. It's staring at us in the face. All of the gaps are there in front of our eyes. And if we want to be positive, we have an opportunity to do positive promotion. We have the opportunity to catch up and to correct things. And we're in the midst of a second wave. And indeed, we need a clear signal. What you need isn't just a matter of coordination. It's a matter of resources. And during the last 25 years, the funding really declined with regard to our healthcare services and networks. We always cut in the area of mental health, in the area of prevention. Mental health, well, is always the poor cousin in the family of health services, and I imagine you're going to be demanding that as of now, the federal government give a clear signal to reestablish our networks and to quickly increase our healthcare transfers as of today in order for this catch-up work to be able to be done. So please don't be shy in saying this. That's not being political. It's simply considering that, yes, we have a constitutional framework such that those who provide care are in the provinces, in the territories, in Quebec. So these people must be able to plan. And Ms. Hetherington, you have beautiful ideas, but you also need money to follow through. There has to be support for those ideas. So would you agree with me to say that the government should right away, as of today even, with our economic update, announce that it's going to be increasing healthcare transfers and in a sizable way, because this just isn't working anymore? Who would like to answer? Clearly, we need more resources. There's no question about that. As I stated, the prevention and promotion programs, that's where we'll have an impact on our healthcare system. We're talking about a healthcare system that is lagging. Healthcare workers are asking for help. We must invest in prevention first. It's very clear-cut. We need more money in the provinces in order to be able to deliver the goods. We must invest in prevention and promotion, both. I believe that all of the prevention programs are the mandate of the provinces, so there should be money available to them to do that work. With regard to promotion, part of this is provincial, but part of it is also a federal responsibility. But I agree 100% with you, Mr. Thériault. We have to transfer more money and have more resources, but this time it has to be clear that it goes to prevention and promotion. When we talk about transfers, there are people who could say, yes, but we're spending a lot of money on COVID. But what we need are sustainable investments, structuring investments that will allow our networks to correct the errors of the past. We have the opportunity to start from scratch and start off on the right foot. I saw in the document that we received this morning around 10 o'clock, Ms. Hetherington, you state that 1 out of 5 people will suffer from a mental health problem or illness. And according to your organization, the direct cost attributable to mental health problems, mental health diseases, support, etc., are going to amount to about $42 million per year. And the direct costs for care against cancer, for example, were of $7.5 million in 2012, and those related to cardiac problems are $12.8 million per year. So these costs are similar to those that we've seen in countries that have comparable situations. England, for example, according to the World Health Organization. So that's not negligible whatsoever. What this tells us that when we tell medical students that the first determinant of health and is prevention, well, those are numbers that clearly demonstrate that we would save an awful lot of money and we'd be much more effective if once and for all we reversed things and invested directly in prevention, increasing transfers in order to do so. Absolutely, I agree completely with you. It's an opportunity indeed. We know that COVID is very hard on people, but it's also an opportunity to change things, to redirect our energies, and to base our action on promotion and prevention, because we don't invest enough in that. That's clear, and it's time for change. Thank you, Mr. Thériault.
6 minutes.
Well, thank you to all the witnesses for being here today and for your riveting and I think quite sobering testimony. Dr. Fairburn, if I may start with you, it's been said quite often in the last little while that there isn't one pandemic in Canada, there are two. We of course have the COVID pandemic, but we have an entrenched opioid overdose crisis that has taken over 15,000 lives in the last 4 years alone in this country. In fact, not to equate them, but that's more lives lost to overdoses than we've currently lost from COVID. On October 28th, Dr. Fairburn, you co-authored an op-ed in the Canadian Medical Association Journal that said the following: swift and decisive action has been crucial to Canada's success limiting COVID-19. The same emphatic response is needed now to combat the overdose crisis. Could you please outline what an emphatic response to the overdose crisis would look like in Canada?
Thank you very much for that question. I completely agree. It's stigma regarding addiction and the lack of acceptance of it as a medical condition that has resulted in kind of chronic underinvestment in services for people living with addictions. And we are losing people who are very young to overdose all over Canada. We need investments both within the healthcare system, which includes developing for the first time a comprehensive addiction system of care where we work up the silos, so where prevention, treatment, harm reduction, recovery are all coordinated and people can access the system rather than consistently butting up against the system. We need expanded access to pharmaceutical alternatives given the fact that it's a poison drug supply, and we need a real conversation, real consideration regarding decriminalization of drugs. We need to be able to fully move substance use out of the criminal justice system and treat it as the medical condition that it is. So amendments regarding the Canadian Drug Substances Act is important. There were some really important amendments that were made at the beginning of COVID-19 to support people to access, for example, medications for opioid agonist treatment. So that was done quite quickly at the beginning of the pandemic, and they're revisiting other ways that the CDSA can be amended to support people who are critically at risk for imminent death due to overdose is also really important in order for us to be able to have a addiction treatment system that people can come into.
Now, thank you for that. Have you noticed any increase during the COVID crisis in the numbers of those people who are seeking treatment?
Yes, we notice increased relapse rates, and I should note that includes people who are elderly in the geriatric population, so all ages. So we're seeing increased relapse rates due to stress, isolation related to COVID, and we're seeing a downscaling of services for people. And the combination is resulting in people, again, increased butting up against the system without any services available for them, including recovery treatment, recovery-oriented services, including harm reduction services that are so crucial in preventing overdose every day.
Now, I think it's relatively commonly accepted now that we know that addiction has a unique feature to it, which is when someone seeks recovery, there's a very limited window in which to get that person into recovery. So treatment on demand, I think, is something that is, I think, commonly accepted as required in order to tackle this issue. Can you give us a bit of a flavor about how Canada is doing in terms of access to treatment on demand?
Sure. Unfortunately, treatment on demand remains the exception to the types of substance use services that are offered. Most of the time, if people are looking to access, in particular, detox or recovery services, there can be a considerable wait, and those delays can result in, adverse harms and deaths during the waiting period. Given that crucial importance of having services available when people try to access them, so I would say, in general, there's a huge gap there in terms of treatment on demand throughout the country, and that delay has worsened during COVID-19. So people aren't even able to become eligible, for example, for wait lists because services are at capacity, given that they're not able to accommodate as many clients as they would have been able to do before even COVID-19. So treatment on demand remains highly limited. That includes evidence-based treatments like pharmacologic agents that can be really life-saving for people, like methadone, buprenorphine, morphine formulations, etc.
Thank you. Well, as you may know, the New Democratic Party has had an official policy of favoring decriminalization of drugs for some time. In July, I, along with NDP Deputy Health Critic Jenny Kwan, sent a letter to the Federal Health Minister requesting the implementation of a Canada-wide exemption from the Controlled Drugs and Substances Act to decriminalize personal possession of illicit substances as an urgent interim health measure. And I think you made reference to the fact that Vancouver City Council recently sent a similar request for an exemption for the City of Vancouver. How
6
urgent
minutes
is it,
to
in
wrap
your
up,
view,
please.
that Canada move towards an official policy of decriminalization so that we can treat substance use and substance use disorder as a health issue? Because there seems to
Wrap
be
up, please.
resistance to do that at the federal level.
I think it's urgent. I think it can be considered as part of urgent second wave COVID-19 response to be looking at decriminalization as a way of addressing the contaminated drug supply that's poisoning Canadians.
Thank you. Thank you, Mr. Davies. And that brings the end of our questioning. I'd like to thank the witnesses for sharing with us your time and your expertise today and for your excellent questions. With that, we will suspend and bring in the next panel. Thank you all very much. So welcome everyone again. So for this second hour, we have Faces of Advocacy. We have Dr. Poon, founder and medical doctor. We have Mouvement Santé Mentale Québec, Madame Ouimet, directeur. Stepped Care Solutions, Dr. Cornish, psychologist. Women's Health Research Institute, we have Dr. Grotto, executive director, and Dr. Ogilvie, associate director. We'll now start with witness statements. Each group will have 7 minutes. Please go ahead, Dr. Poon. 6 minutes, please, or 7 minutes, sorry.
Thank you very much, Mr. Chair. Mr. Chair, my name is Dr. David Edward Poon, founder of the Faces of Advocacy. We are a grassroots Canadian organization of over 9.5 thousand members, established to safely reunite families in Canada during the COVID-19 travel restrictions. From my understanding, we are directly responsible for the extended family travel exemptions announced on October 2nd, 2020. As Canadians brace for a second wave of COVID-19, government policies must ensure families are reunited and kept together in order to abate the shadow pandemic of a mental health crisis. These are the unedited statements from members suffering due to COVID-19 related family separation. Life doesn't feel worth living. Fixing it is out of my control. I don't know how long I can keep going. After 225 days apart and no history of mental health issues, my most recent panic attack was last night. As a healthcare provider, I have never fully understood addiction until the separation from my partner. The constant feelings of despair, hopelessness, sadness, and anxiety since March gave me this unwanted lesson. I cry. My son cries. He thinks it's his fault. 2020 is a rough year for all. Imagine going through it without your family. During our Faces of Advocacy Mental Health Index, we surveyed the mental health of over 1,200 of our members using validated clinical tools, showing a near doubling of suicidal self-harm thoughts due to COVID-19 related family separation. 60 to 70% of respondents showed moderate to severe symptoms of anxiety, depression, and/or PTSD, where 49% of respondents had never been diagnosed with a mental illness prior to the family separations. Only 34% felt that they had adequate mental health support during the pandemic, and 84% responded that their mental health decreases the longer they are separated from their family. A coordinated federal strategy must be implemented for all Canadians, including permanent and temporary residents. Our briefing includes 6 recommendations. I will highlight 4. Number 1, Donna's Rule. Donna McCall is a Canadian nurse and mother whose American children were not allowed into Canada as she died. She said goodbye to her children on FaceTime. The mental health sequelae of that moment spans a lifetime. Family reunification must be prioritized to protect the mental health of Canadians. This can be done through the Ministry of Health alongside IRCC, Public Safety, and others to offer a reasonable path for family members to reunite at a time of crisis. Number 2, the last goodbye protocol. There must be a federal guideline ensuring reasonable accommodations.
Excuse me, Dr. Poon, could you slow down a bit? I think maybe the translators have to keep up with you. So.
The last goodbye protocol. There must be federal guidelines ensuring reasonable accommodations for Canadian families to have an appropriate bedside presence. So even if families are allowed in the same city, hospitals do not have a uniform bedside process, particularly at the end of life. So in our briefing, we have the first-hand account of an ICU nurse detailing the mental health pains families go through from this lack of clarity at end of life. Provided that sufficient resources, such as personal protective equipment, are available, hospitals must allow culturally sensitive and safe opportunities for some family to be present for critically ill patients. So the basic idea is during COVID, you had patients whose family were maybe in the hospital, but could not say goodbye to their family member. We have PPE now. We can educate patients on how to do so safely, but the mental health outcomes of not being there for a proper last rites ritual have long-standing repercussions and must be addressed for the mental health of Canadians moving forward through COVID. Number 3, there must be a federal mandate for virtual care under the Canada Health Act. This would protect virtual or phone billing codes for primary care and mental health physicians to ensure accessibility, comprehensiveness, and portability of mental health care for Canadians. So this mandate must consider that physicians licensed to work in Canada may be displaced during the pandemic, but are still able to provide virtual treatment. For example, a physician in Saskatchewan is able to call patients in Saskatchewan. If that physician is displaced during the pandemic and is in Ontario, that physician should still be able to call the Saskatchewan patients in order to provide care. This will ensure continuity and consistency with the Canada Health Act. So far, Saskatchewan operates like that, but Ontario doesn't. So that is why there must be a federal mandate. Point number 6 on our recommendations are the end of the tunnel health strategies. So what we require is a federally mandated, federally managed national COVID-19 vaccine program. Provincial distribution would be subject to possible inequitable distribution amongst the most vulnerable. When that is seen by members of Canadians, that can severely adversely affect mental health. We already see how mental health of Canadians deteriorates given that they see other people flaunting public health guidelines or not following masking mandates. Imagine what will occur if there is not a transparent, equitable process for a national COVID-19 vaccine program. Immunizations for COVID-19, when available, must be equitably distributed at no cost. This includes the elderly and the immunocompromised. This must be paired with a modern countrywide surveillance system to ensure proper calculations of response and attack rates, immunity, and outbreaks. The reason it is federal and not provincial is to ensure transparency as well as consistency across the entire program. Now, the other part of the end of the tunnel health strategy is once COVID-19 testing is proven to be reasonably accurate, a federal inquiry into testing must be considered as a replacement for the 14-day quarantine. It is the largest barrier to family reunification at the moment, as some people are unable to take a full 2 weeks off to see their family member. A federal inquiry into the efficacy, usefulness of testing is needed. Family is essential in life and in death. COVID-19 forced us to face mental health challenges in both. This briefing recommends strategies to reunite families safely, reasonably, and accommodate end-of-life reunification in a considerate manner, while simultaneously promoting and protecting mental health. Thank you, Mr. Chair.
Thank you, Dr. Poon. We go now to Mouvement Santé Mentale Québec. Madame Ouimet, allez-y.
Go ahead, Ms. Ouimet. You have 7 minutes. Thank you very much for your invitation. I'm going to be dealing with promotion and prevention in mental health. We are an umbrella organization of community groups that work in the area of promotion and prevention. We have members throughout Quebec. We've been in existence since 1955. Our mandate is to create, develop, and reinforce mental health. In other words, to act in order to try to maintain at all times population that is healthy mentally, be it the general population or workplace groups, etc. I would like to mention things that haven't yet been brought up, I believe. It's a message I would like to leave with you. Mental health is something that is good, that is positive, and it's not mental illness. When we talk about mental health, it's an individual source of wealth, a collective source of wealth. And the World Health Organization says that without mental health, there is no health, period. And we must remember this. It's a dynamic balance in the various spheres of our life. It's not easy to maintain in today's context, but the promotion of mental health is really to work in order to increase daily and improve daily personal and collective well-being and to help the population to develop their robustness. So it's an ongoing process that lasts throughout your life from birth to old age. The pandemic was a revelator of various issues. There were already people who were in difficulty. A lot of young people were at school and they were already anxious and distressed, some of them very intensely. A lot of teachers believed that they didn't have enough resources. There were a lot of people in the healthcare system that were running out of energy, and the pandemic allowed us to see through this, and this might be a positive outcome. It allowed us to look at the situation through a looking glass. We were able to see things that weren't working as well as they should in our society. Some people are resilient, but others are not so much so. Something we must remember is that there are a lot of people who say that we're all in the same boat. Well, we're not in the same boat. We're all on the same ocean, but some people have little cardboard contraptions and others are on cruise ships. So there's a balance. Even in the pandemic, we're not all in the same situation. I do hope that we'll be able to draw lessons from this pandemic. And in the area of promotion, there are two areas where it's important to act. It's important to act with regard to social health determinants, and we know that the most fragile amongst us, the poor, have greater mental health issues. So we must combat this. We must improve access to education. We must fight against poverty. We must be very mindful of our policy interventions. Our policies must be universal, apply to all, and we must develop public policy that integrate special attention to mental health because as I said at the outset, without mental health, there is no health at all. At Mouvement Santé Mentale Quebec, we have 7 little tricks or guiding principles. You can find this in English and in French on our website. And an American researcher intervened. He carried out research with American soldiers who had been detained for 8 years and who left prison without suffering from PTSD. He carried out research on this to try to determine what allowed them to be released from prison without having suffered from PTSD. And what came out of his research are these protection factors, the ability to act. Mr. Edouard was mentioning this earlier, the importance of discovery, etc. Anyway, you will be able to look at this at your leisure, these aspects that we should integrate in our daily lives, in our policies, in our schools, in our interaction with seniors at all times. I read several research studies, and the elements that come out of all of this work, you've probably heard them already. One element that really protects mental health is trust in our authorities. We know that in Canada and in Quebec, during the first wave, there was less distress than in the U.S. and in other countries in the world because people trusted their authorities, and it's important to maintain this trust. People must also have access to exact information. And research has been done on this, saying that if you have a strong feeling of cohesion, it protects your mental health. And this is what happens when you're able to understand what is happening to you, to have information in order to face the situation, to be able to give meaning to it, and to determine measures to be taken. It's important to remember that we can all cooperate in developing and helping people develop their feeling of cohesion by providing exact information, examples that hold up to scrutiny, and by helping people find solutions. We often talked about emotions, feelings, but I met recently with a researcher who talked about the importance of accepting our emotions, no matter what they are, before they hit us in the face. So we must listen to our own signals and those of others. That's our barometer. When the feelings are there, the emotions are there, they flow from a need, and we must listen to the need and be attentive to the needs that's there. Sometimes there are social emotions, social anger that we listen to, and we intervene, and it can have a positive impact on the mental health of the population. There are all sorts of other types of emotions as well. We must feed positive emotions. We must talk about people who are doing well during the pandemic. There are businesses that find solutions, that are innovating, that make fantastic discoveries. There are policies that are really interesting that we're seeing put in place, and it's important to talk about them. You're closing in on your 7 minutes. Yes, I will conclude by insisting on the importance of having welcoming and caring workplaces that protect mental health. We know that there is 24% less psychological distress when your workplace is caring, and we have to break down social isolation. That, too, is a very important aspect. Thank you. Thank you to you.
Solutions, Dr. Cornish. Dr. Cornish, go ahead. 7 minutes, please.
Thank you very much. I'm going to speak about the availability of mental health promotion programs, in particular focusing on Wellness Together Canada, which is a federally funded program that Step Care Solutions launched in partnership with Kids Help Phone and Homewood Health. I'm also going to speak as a researcher to the role of virtual care in increasing access during the pandemic. And having worked with both provincial and territorial and the federal government, I'm also going to speak to the role the federal government could play in supporting provinces and territories. So my nonprofit company, Step Care Solutions, is the lead partner for Wellness Together Canada, and our diverse team is comprised of psychologists, social workers, IT experts, and perhaps most importantly, people with lived experience of mental illness. And we developed the Step Care 2.0 model originally in Newfoundland and Labrador, and it is now scaled across the province, both in population health and in clinic-based settings. And we're working now with the Northwest Territories to do the same kind of implementation. The model informed the development of Wellness Together Canada, which was implemented in April over a period of 10 days, and so very rapid implementation of a virtual portal. And we're now working on improving the user journey as informed by the stepped care model. The original structure, of course, being implemented very, very quickly was really, we wanted just to get tools and counseling in the hands of Canadians. But we realize in virtual world how important the experience of being on a portal and how the portal looks and feels. It's really the equivalent of what we call in mental health, the importance of the common factors for producing good outcomes, which have a lot to do with the relationship, or in more sort of colloquial terms, the bedside manner. And what we really want to emulate is the sort of I guess the romantic version of the rural physician who by very essence and personality kind of invokes a sense that things will be okay and I'm under your care. So anyone in Canada who visits the Wellness Together portal will have the choice of 11 independent evidence-based and evidence-informed programs available 24/7, including immediate mental health crisis tech support, but also self-assessment and tracking tools so you can monitor wellness, self-guided tools based on cognitive behavioral therapy, peer-to-peer support, coaching and e-courses, and of course, one-to-one counseling. To date, almost 700,000 people have accessed the program, and of these, approximately 60,000 have registered for ongoing care. 78% of users that we surveyed through a random survey a few months ago indicated that they would recommend it to a friend, which is an indication that they are satisfied with the program. Some national polling indicates that people do have some concerns for privacy and fears that the programming on the portal would cost money. And this is not true, of course, it's free, but we know those perceptions are out there. And around privacy, what we discovered was that there are some fairly simple things when we asked people what could make the experience better that we can do on the portal, and we are redesigning to address those concerns. I want to turn to the role of virtual care in general, increasing access during the pandemic. There's some recent surveys on virtual clinic care experiences, including surveys on Wellness Together Canada, that indicate that help seekers like telemental health, much more than we previously thought. Clinicians, my colleagues, psychologists, social workers, psychiatrists, and physicians are not as pleased with virtual care. And I think that we will need to invest in more training and support to bring them along, but the population likes it. Another thing I want to emphasize around what we've learned through the pandemic is that virtual care has much more potential. It's much more than teletherapy. Teletherapy is doing what we normally do, but using a system like Zoom right now, where we can deliver psychiatric or psychotherapy care. What we're finding is it's just as effective, but there's so much more we can do in the digital world to accelerate long overdue system innovations, developing and continuing to develop and invest in things like portals like Wellness Together Canada with population health programs, what we call one-to-many solutions. So you have a webinar that can be delivered to thousands of people at once. Continuous wellness monitoring. We actually don't do a lot of this continuous monitoring and put that data in the hands of users in our healthcare systems. This could be scaled up nationally in clinic settings and, of course, as we're doing with Wellness Together Canada. More rapid access to care. With Step Care 2.0, people get access to a variety of care immediately. And on the portal, you get it immediately, whether it's a counselor or using self-help self-guided programs. What we're finding through some polls is that virtual care appears to promote more equitable access. We're finding that there's a much more even distribution along gender lines on the Wellness Together Canada portal than we see in clinic settings. And racial representation of users is more representative of the population. I want to conclude with a few points where I think the federal government could take on a continued role. And it's in investing in technology infrastructure. We know that in the north, and in rural areas, broadband access is difficult and is often delivered by satellite. And we need to change that because you cannot access these programs as successfully, the Wellness Together programs, in rural and remote places in Canada. We need to continue scaling population level programming, develop more self-guided, improve self-guided programming. People really like it. That's the thing they're going to the most on Wellness Together Canada.
Please wrap up.
Okay. And so finally, what I'd like to say is that the federal government could take a role in integrating both on municipal, provincial, and national levels to fill the gap that exists with mental health, which the gap is immediate care for people who need it most, including those who are homeless and suffering from addictions. This model, this portal can be expanded to provide that support.
Thank you, Doctor. We go now to Women's Health Research Institute. Dr. Brotto or Dr. Olkovi, please go ahead. 7 minutes, please.
Thank you so much for inviting us to speak with you today. And I want to acknowledge that our work at the Women's Health Research Institute is situated on the traditional, ancestral, and unceded territory of the Coast Salish peoples. That includes the Musqueam, Squamish, and Tsleil-Waututh nations. So with regards to COVID-19, sex disaggregated data reveal a higher case fatality rate for males compared to females. Of note, however, there are exceptions in some countries, such as India, where case fatality is higher in females. In a comment published recently in the Lancet Global Health, the authors speculated whether these higher rates in females might be due to factors related to their gender. We already know that pandemics can compound differential exposure and outcome for women, girls, sexual and gender minorities, caregivers, and other essential workers in gendered occupations. So we at the Women's Health Research Institute designed a two-part study that combines a survey as well as examination of antibodies collected by dry blood spot sample. In our remarks today, we will only focus on a snapshot of the mental health outcomes. I want to acknowledge our full team at the Women's Health Research Institute and colleagues from BC Children's Research Institute, as well as all of the students and trainees, as well as funding from our BC Women's Health Foundation.
Thank you, Dr. Brotto. A significant strength of our project is that it draws from 7 existing cohorts that are representative of women in BC, totaling over 40,000 individuals who have consented to be contacted for future research. These individuals received an email invitation that described the study aims and obtained their e-consent. The link then took them to the survey, which consisted of 1 core module focused on a comprehensive epidemiologic survey on COVID-19 related symptoms and risks, sociodemographics, medical history, and vaccine attitudes. They then proceeded to 4 modules that focused on substance use, psychosocial outcomes and gender-based violence, underlying comorbidities, including HIV, economic outcomes, and healthcare disruptions. Where appropriate, such as with the psychosocial outcomes, we employed validated clinical scales. At the end of the survey modules, participants were invited to send the survey link to another household member who identified as another sex or gender. They were also invited to provide their address to receive a dry blood spot kit to measure antibody responses, and those are being prepared to be sent out right now. So participants were stratified into 9 5-year age stratas from 25 to 69, with a target for recruitment of about 750 participants for each of those strata, for a total of 6,750 participants. The data we're going to discuss today are based on responses from about 5,300 individuals out of an approximate 15,000 invitations sent out. So we had a response rate of about 30%. Now, just to be clear, while we administered the survey at one time point, for some of the questions, we asked people to think about their experiences for 3 specific periods of time. The 3 months before the pandemic, pre-pandemic, during phase 1 of the pandemic, which was mid-March to mid-May, and phase 2, which started after the middle of May. Going forward, we're continuing to collect longitudinal data. So for our results. The mean age of participants was 51, and most of the respondents so far identify as female at 87%. In terms of gender, we had 59 individuals who identified as trans or non-binary, 31% were essential workers, and over half reported chronic health conditions. For this presentation, we will report on rates of overall depression, moderate and severe depression, anxiety, loneliness, distress, intimate partner violence, and alcohol and cannabis use in the defined 3 phases of the pandemic. We plan in the future to report on these analyses by gender, by culture and ethnicity, including indigeneity and race, as well as other sociodemographic variables once our target sample size is reached.
Thanks, Dr. Ogilvie. So moving on to depression, first of all, comparing males and females and consistent with what we would have predicted based on past pandemics, there was a significant increase in depressive symptoms that was quite a bit higher in females compared to males as we moved from pre-pandemic to phase 1. And as pandemic controls started to loosen, we found a decrease in those depressive scores. When you separated the data by age and not sex, our data show that the highest burden was borne by the youngest age group of those aged 25 to 30 years old. And among our sample of trans and non-binary individuals, their scores were clinically significantly higher than the females. We then moved on to look at extreme depression. For females, they experienced a 4 times greater increase in their rate of extreme depression from pre-pandemic to phase 1, which was clinically significantly higher than the males. Regarding the trans and non-binary group, their pandemic rates of severe depression also doubled from pre to phase 1. Anxiety can be defined as the fear of the unknown combined with a loss of control. So using a validated measure of anxiety that taps into worries and anxiety, we found a very similar pattern to what was found with depression. Significantly higher rates for females and a significantly greater increase from pre-pandemic to phase 1, with the highest burden being borne out by the youngest age group of 25 to 30-year-olds. This was also found when we focused specifically on clinically significant anxiety, where nearly 20% of the females during phase 1 of the pandemic fell into clinically significant anxiety rates. One facet of depression is loneliness, which we asked about in a separate question. Again, the sex-specific findings were replicated, and the highest burden was borne by the 25 to 30-year-olds. Moving on to intimate partner violence, or IPV, emerging data do show that since the outbreak of the COVID pandemic, reports of IPV have increased worldwide as a result of mandatory lockdowns. We asked about a list of behaviors like being hit, thrown, kicked, beaten, etc. And our data were based on the female population only who were in a relationship.
7 minutes. Could you wrap up, please?
Thank you. There was a near doubling of rates of intimate partner violence from pre-pandemic to phase 1. Finally, among alcohol and cannabis groups, we found that 1/3 of the participants reported an increase in alcohol use, and 40% in the youngest age group reported an increase in cannabis use. So in summary, our data show significant effects of sex, with females being disproportionately more impacted when it comes to depression, anxiety, loneliness, overall distress, and significant increases in intimate partner violence. And we recommend a sex and age-specific tailoring of mental health resources based on these data. Thank you very much.
Thank you, doctors. We'll start our round of questioning. We will have time for one round of question, and we will go over somewhat the hour. We start with Ms. Rempel-Garner. 6 minutes, please.
Thank you, Chair. To Dr. Poon, how many of your members do you think can afford to take the 2-week quarantine period to reunite with their loved one?
We are thankful that the Government of Canada has allowed family reunification to occur, although much later than we expected. The question is, though, how many of them can afford not only the 2-week quarantine once they arrive in Canada, as well as the 2-week quarantine back when they go to their home country. Now, this is not to be disparaging and to be flippant about the health and safety of Canadians. There must be a safe pathway to do so. That is why in our recommendations, we believe that there must be an inquiry to alternatives to
Dr.
the 14.
Poon, my 6 minutes is going to go really quick. So I'm
Sorry,
just wondering, I'm just wondering, do you think many of your members can afford that 2-week
No,
quarantine?
they cannot.
Yeah. Look, this is probably the first time I've ever done this in my time in Parliament, but I'll just get personal for a second. I didn't expect a tall, dark, and handsome American to come into my life. I'm glad he did. But even in my position of privilege, it was over 5 months that I was separated from my husband this year. And it was only because of the Alberta pilot project that we were able to see each other. And it's really hard. It's really hard. I don't get to see my kids. I don't get to see my mother-in-law who has stage 4 breast cancer, and it's hard. And this is me as a legislator sitting in this committee right now. And you guys, everyone on this committee knows I'm tough as nails. And, I know some of the names the Liberals call me, but every night when I come home alone, it's hard. And this is me. So I'm just wondering that if there are alternatives to quarantine that have better public health outcomes, like if we could test everyone at the airport as opposed to letting 4 million people come in untested who may or may not observe the quarantine. I know there's quarantine exceptions for that many people over the last several months. I'm just wondering, given that you're a clinician, Dr. Poon, if part of your recommendation is to expand systems like we're seeing in Alberta to other airports and other border crossings across the country so that it can aid in family reunification.
The system in Alberta, along with the pilot in British Columbia for airport testing, along with the pilot in Ontario for airport testing, will offer wonderful ways to increase the number of reunited families, particularly if we apply what's being used in airports to the land borders, which should be helpful. Once again, we are not asking for open borders. We are just asking to be together, and we want to be together safely.
Yeah, I hear you. I guess I wanted to explore a little bit more about your recommendations around family reunification for compassionate visits. I know I was particularly moved by a case in Manitoba recently where after months of begging and procedural work, somebody was granted an exemption to come into Canada to see a family member who was in the hospital, but then couldn't reunite with them before they passed because there was no exemption to quarantine, even if a test was administered. Are there other countries around the world that are doing this that we should be looking to for best practice?
So there are many countries in the world without particular border standards restrictions that Canada has. The compassion exemptions have been worked in through different family reunification on a case-by-case basis in other countries. For example, in the US, you can actually just fly over right now to see a loved one who might be passing away. Donna's rule, which I'm suggesting, must be a federal government mandate to prioritize family reunification in the times of crisis, because we must not.
I think we lost you, Dr. Poon.
Dr. Poon, you're muted.
We cannot have families say goodbye to their mother when she's dying through FaceTime. There must be, Donna's rule, to prioritize family unification at a time of crisis.
I think personal stories are important right now. You're a clinician. Can you summarize what it's like on behalf of everyone in your group, as well as your experience, what it's like to be separated from your loved one for over half a year, for months at a time?
I asked members of the committee to consider, if there's a worldwide pandemic, who do you want beside you? The answer is uniformly your family. Imagine the moments lost, how many miscarriages were taken alone, how many deaths were felt by yourself, and how many tragedies you had faced without the support of your loved ones. This level of pain, we understand, needed to be worked out, but now that we are here, now that we're preparing for the second wave, we must not allow the mistakes that happened earlier in the year to create further family separations as we approach the second wave.
And how critical does rapid testing and widespread availability to testing play into this?
Rapid testing, rapid availability of testing are just more tools to allow family reunification, whether or not that's a mixture of quarantine, testing at the border, point of care, anything that we can do to bring families together in a case-by-case basis through broad exemptions is of the utmost importance during the second wave of COVID.
Thank you for everything that you've done, and thank you. My heart is with everybody in your group. Thank you, Chair.
Thank you, Ms. Rempel-Garner. We go now to Mr. Kellaway, please, 6 minutes.
Thank you, Mr. Chair, and I'll, there's my video. I'll share my time, Mr. Chair, with MP Van Buyden as well. So I want to thank all the witnesses for being here today. When we talk about mental health, it's usually talked about as a blanket subject that affects everyone the same. And as my colleagues know, I represent the wonderful people of Cape Breton-Canso, and that riding encompasses the island of Cape Breton in northeastern Nova Scotia, which is predominantly rural. And I know many rural Canadians experience unique challenges when it comes to mental health, and that there are other groups that are impacted differently as well: seniors, women, Indigenous groups, racialized Canadians, children, and so forth. And this question is for Dr. Cornish. What can we do to ensure that mental health support in Canada is intersectional, to better support all Canadians, especially those with unique needs and challenges?
Yeah, I mean, I think thank you for that question. It's an excellent question. What our current system has a one-size-fits-all approach. You can go to a physician, you can go to a psychologist, you can go to a psychiatrist. What we're learning with opening up the buffet of options is that it fits much more with the reality of our society, which has people of all kinds of different identities and intersections on gender, race. And what we find is that the typical, access to care is often blocked by protocols that triage or try to diagnose at the front end and do a lot of heavy assessment, in which case a first point of contact, whether it be by phone or in a consultation room, the person doesn't walk away with any care at all because they're busy answering questions. And I have a personal story myself. My daughter tried twice when she was a teen in university to get access to care. And she walked away from the counseling center saying, all they did was ask me their questions. They never actually asked me what I wanted. And then she went to the private sector thinking she would get better care. And again, it was the therapist's questions. The therapist thought they knew better, and they thought they had to ask everything, turn over every stone and ask every question to find out everything that's wrong with my daughter before they could help. Physicians don't do that. When I go to my physician, they don't ask me everything that's wrong with me. They ask me, why am I here? What do I want? And they make sure that I walk away with something useful. We've never done that with mental health. We assume that experts know what questions to ask, and this is not appropriate given that we have people of different gender orientations and different cultural backgrounds. We shouldn't make any assumption about what they need. We should start by saying, what would be helpful today? And trust that people, in most cases, can answer that question better than we could as professionals. And that's what we're doing with Step Care 2.0. That's what we're doing with Wellness Together Canada, is we're giving mental health back to the people who are seeking support, rather than keeping it in a secret professional sort of, assumptions about what will work for whom.
Thank you, Dr. Cornish. I'll hand it over to MP Van Buyden for his questions. Thank you so much for all the work you do.
Thank you, Mr. Chair. Thank you, Mr. Chair. And firstly, let me thank Michelle Rempel-Gardner for sharing her personal situation with us. I'm a member of the all-party mental health caucus, and each and every one of those individuals were brave enough to share their personal experience with us. And I have to say that it's heartbreaking, and so it advances my commitment and emphasizes the importance of what we're discussing now. My question is for Dr. Cornish. There are many people who do not normally experience mental health challenges are reporting them because of the impacts of COVID-19 pandemic, but some may not feel comfortable asking for help in these challenging times. How can we break some of the stigma associated with the mental health issues and encourage them to seek help?
I think, again, the one size fits all thing has to be abandoned. And what we're finding with veterans, first responders, frontline workers, quite often the sort of culture in these workforces is such that you shouldn't ask for help, or that your job might be in danger if you disclose a vulnerability. What's proving to be very successful with those populations is peer support, communities of support. And what I think the federal government can do is set up an infrastructure. Peer support works with the support of technology because you can scale it, and you can scale it in a way that's anonymous. Because part of the concern when reaching out for care is that it might be somebody that I know in my neighborhood in a rural area, especially with peer support. But with technology, you can make that anonymous, and you can also scale it to the point that there's enough people available to provide support, a listening ear. What we find with peer support programs and volunteer workforces is the turnover is high. This is not a problem, because when you train a peer support workforce, and they may not work for a long period of time, but then they're still within our population, able to provide informal support because they've learned skills on how to help each other. But to the point of scaling, because the turnover is high, is you need to have an infrastructure in place that continually replenishes, teaches mental health first aid for peer support workers.
Thank you.
Thank you, Dr. Cornish, and thank you, Mr. Van Buyden.
Thank you.
We go now to, nous allons maintenant à Monsieur Thériault. Monsieur Thériault,
Mr. Thériault, you have 6 minutes. Thank you, Mr. Chairman. I would like to thank all of our witnesses for their precious collaboration today, their very enlightening testimony. Today, we received very little documentation, very few briefs. I would invite you to table them. These briefing notes will be very useful to us. Ms. Ouimet, at the outset, you indicated that your organization was working on developing and reinforcing mental health, especially in the workplace. We're concerned with a new reality with COVID. It's telework, people working remotely, working from home. There's a study that was done by Laval University. It's the work of Caroline Biron with colleagues, and there was a sampling of 1,259 workers in Quebec during the spring. And psychological distress reached 55% of female workers, 41% of male workers. Having the opportunity to work is better than to be without work, but at the same time, and here I'm not talking about health and doctors, but some companies are delighted with telework, but at the same time, what we're seeing is that telework has imposed isolation and amplified isolation. I would like to hear you on this. I would like to say that Ms. Biron's research didn't just deal with telework, but indeed telework does greatly isolate workers, and we have to put in place new ways of doing things because there's less social support, there is less technical support as well. We know that people will not be able to exchange with their colleagues on the difficulties they encounter, on all sorts of situations that arise. They find themselves more isolated. They no longer have breaks that they can share together. They can't exchange apart from in the context of work meetings. And with regard to technical support, there's a lot less than previously. So it's our duty to create what I would call new structures, time for exchanging with colleagues to see what support people might need so that they can talk about what they're experiencing and just not on the technical side of things. Also determine what technical support is necessary. So it's our duty to create new rituals, new methods for meeting when workers, men and women, and their managers want to meet. We also know that even people who are there in person encounter difficulties because of physical distancing and other requirements. I'm curious, the male-female gap, 55 versus 41%, is it a constant? Is it a variable that's already there? Do you have any responses, any answers for me? Well, I exchanged with Ms. Biron, and what she said was that there was no specific research done on that, but what we do know is that women, even today, have a greater burden with regard to reconciling work-family life, household tasks. There's a larger responsibility that falls on the shoulders of women. So indeed, it has an impact on their mental health. The mental weight, yes. So workplace, mental burden, isolation, no tools to share, all of the pressure, spread it around. So you're isolated and you have to perform. Yes, and workplaces are such that women are often called upon to hold positions where they're helping in the service industry, etc., and that too has an impact on the mental health of women. In a context of resource shortages and of worry, yes, it increases it. In the context of the pandemic, when we offer healthcare services, care, when you work in public services, when you work in grocery stores, etc. These are workplaces where you're facing these challenges daily. I would like to talk to you a little bit about the mental health of young people. Based on analysis that was published in October, 46% of Montrealers aged between 18 and 24 years of age state that they have symptoms that resemble generalized anxiety or major depression even. Elsewhere in Quebec, it's 31% the rate. So close to 1 adult Montrealer out of 4, 23% report that their household has suffered major economic distress. Please conclude, Mr. Theriault. What would you have to say about that? In 15 seconds. Well, yes, that's the age when you're starting to work, you're structuring yourself as an adult, and there was already a lot of distress at school, in universities, in CEGEPs. So that is rising. There was more isolation, less social interaction with one's family and friends and loved ones. What can we do? Well, listen, employment remains important with regard to having strategies for social encounters. It doesn't mean necessarily in person, but solidarity must continue, must be maintained. We have to listen, our young people, our loved ones. It's essential, and we have to make them aware of all the resources that exist, because unfortunately, these resources aren't well known, and we receive all sorts of calls from people who don't know where to call out to get help. Thank you.
Theriault. I would like to comment regarding documents. All documents that we receive will be distributed to the committee once they're translated. So we go now to Mr. Davies. Mr. Davies, please go ahead. 6 minutes.
Thank you, Mr. Chair, and again, thank you to all the witnesses for being here. Dr. Brado, I had a feeling that you had more to say when you were summarizing the findings, so I just wanted to turn it back over to you to sort of complete your thoughts on some of the major findings that you found from your study on the impacts of COVID on women and gendered Canadians.
Thank you very much, Mr. Davies, and thanks for the opportunity to emphasize the importance, first and foremost, of when we're doing research, when we're considering mental health among Canadians, that we take both a sex-based approach, sex being defined as male versus female, sort of our birth assignment, but also really importantly, gender. And gender is your sense of yourself as woman, man, non-binary, trans, two-spirit, etc. And sometimes when you ask a person about their gendered experience of mental health, it might look different than what we might assume our sex assignment tells us. So that's, I think, a really important first conclusion, that we keep both sex and gender in mind. Secondly, I think a major conclusion based on our data is that when we consider the burden of depression, anxiety, stress, loneliness, that we see magnified rates, and sometimes 3 to 4 times higher rates of those psychosocial outcomes for females compared to males. And that's likely a combination of biological factors, being more predisposed to anxiety, et cetera, but also gendered aspects relating to women being more likely to be frontline healthcare workers, serve in industries that continue to work throughout the pandemic, service industries, janitorial staff, as well as bearing a higher burden of home childcare and domestic activities. So it does lead us to conclude that when we consider mental health resources, that we do keep sex and gender at the forefront of making those decisions. And secondly, and this was asked in the previous question, we saw a very significant effect of age. And as Ms. Dumais was illustrating, the highest burden was borne out by our youngest age cohort, the 25 to 30-year-olds, reporting very high rates of loneliness. We didn't have time in our data, but hopefully you'll see these in these slides, that we also took a very intersectional approach. And we know that individuals living in rural communities, Indigenous women, women with disabilities, and women identifying as sex and gender minorities see all of these burdens magnified.
Thank you. Now, I know that on November 24th, just days ago, the Women's Health Foundation, I think, published a new report series called Unmasking Gender Inequity. Was that report informed by your data?
Thanks for that question. Yes, so the BC Women's Health Foundation, who we work in close partnership with, conducted a separate survey that was really intended to look at women's experiences in the province of the impacts of COVID on their health and well-being and health-seeking services. So while it did not draw from our research data set, we work very closely with the foundation to share findings, to set priorities, and to ensure an equity lens is placed whenever we ask questions that pertain to women's health.
Kind of a double-barreled question here. One of them is, I think we have the, I think one of the most acute and I think disturbing impacts of the COVID pandemic was revealed when you described the impact on gender-based violence, and I think it's been referred to as a shadow pandemic. So my first question is do you have any recommendations for steps that the federal government could take to address that aspect of the pandemic? And maybe I'll just leave it at that and ask that question first.
Yeah, thanks, Mr. Davies. So indeed, we saw a near doubling of the self-reports of intimate partner violence among women from pre-pandemic to phase 1 with the highest pandemic controls. And this is not surprising. Past pandemics found the same thing, and early data out of China showed us a 3 times higher rates of intimate partner violence. The real concern here is that women are often trapped and isolated with their perpetrators. So even if they wanted to ask for help, they simply can't. So we need a multi-pronged approach. First of all, we need to raise awareness about the fact that intimate partner violence rates are unacceptably high and they increase directly in response to stress. Secondly, we need to ensure that healthcare providers, frontline healthcare providers, are equipped with how to ask those sensitive questions in a safe way to women at their general wellness visits, which I understand are largely done through virtual care. And thirdly, we absolutely need more resources so that when women do ask for help, and I emphasize only a small minority of women ask for help when they're in an intimate partner violence situation, that resources are available for them. And so thinking about how can resources be available online, coming back to Dr. Cormish's really important points about virtual care, and how can we ensure that those resources are available to women. Finally, the last thing I'll say about intimate partner violence, we know it is disproportionately experienced by Indigenous women, women living in rural communities, and women who experience other sex and gender-based intersections. So ensuring that when we do have resources, that they are absolutely tailored to those communities who are most likely to be experiencing it.
Thank you, Mr. Davies. So thank you, everyone. That wraps up our questioning for this panel. I really do appreciate all of the witnesses who shared their time and their expertise with us today. It's very helpful. Before we adjourn, I'd like to make particular note of the translators. The translators, day by day, minute by minute, they work tirelessly behind the scenes to make this work for us. And I understand they had a fairly chaotic day today. So I'd just like to acknowledge them and thank them in particular today and every day. So thank you, everybody. And thanks all the members and witnesses. And we are now adjourned.